Welcome to In the Clinic by Dr. Butch Levy. This month's episode is titled GI System Diseases Part 2, specifically the stomach and esophagus and the liver and gallbladder.
This month, we're going to continue our discussion and presentation regarding the GI system. And this month, we're going to discuss the stomach and esophagus kind of as one unit. We're going to discuss the liver and gallbladder. Let's begin, and we'll talk initially about gastroesophageal reflux disease, or GERD, and we're going to talk about upper abdominal pain, dyspepsia. So I'm going to review a little of the physiology related to GERD. GERD is a concept of acid reflux. It usually involves an overproduction of acid. Usually, we'll go into that a little further. But what happens is that acid tends to irritate the stomach. And if the pressure in the esophagus is reduced or compromised in some way, then this acid can reflux up the esophagus. It can go into the throat, can go down into the lungs. It can cause sinus irritation. Obviously, acid is very problematic for people. So when people present with a lot of symptoms, they're obviously put on the commonest medications probably used today in terms of the acid blockers. So we're going to review gastrointestinal disease. And then there's a separate item where you might have reflux and burning, but you don't have pain. And some people get pretty severe pain. Gallbladder disease. People find out they have gallstones because they had some other kind of imaging. It's very rare to have people, they can, but people often don't present for the first time not knowing they had gallstones. Usually they're seen asymptomatically on imaging, and most of the time that's the way they stay. You'll see that it says here after 10 to 15 years, only 25% become symptomatic. Usually when we see people that are presenting with gallstones and biliary colic, as it's called, they've had episodes in the past and just never mentioned it, or maybe didn't recognize that they had, some nausea and vomiting and had some pain and thought maybe they had a bad meal. But when you look back historically, you usually see that people with gallbladder disease have been having symptoms. And once they start having symptoms, it becomes much more risky that they could have a complication in terms of a gallstone getting stuck in the gallbladder or in the common duct or having an infection. So once you become symptomatic with gallbladder disease, it usually is going to point to the fact that you're going to need to have surgery at some point, usually. Moving on, I really wanted to discuss liver disease, and certainly there are a number of different types of liver inflammation. We have alcoholic hepatitis, hepatitis B, hepatitis C, and the common pathway for these is moving from inflammation to fibrosis, and on the road down all the way to cirrhosis, which moves. Fibrosis is a fibrous, cirrhosis is scarring and complete damage to the cells. And when you have cirrhosis, you're at much higher risk of developing liver cancer. So there is this pathway that people follow if things cannot be treated. Certainly with alcoholism, it's often difficult to get people to stop. These days with Hepatitis B, still difficult to treat. Hepatitis C, the newer treatments actually can cure the disease. And the recommendation obviously is for those that are in their 60s, 70s, 80s that lived in a time where perhaps they might have been exposed to needles or had an exchange of fluids that might have passed Hep C, you should really at least have liver functions and get it checked out. Now, generally with liver function testing, you usually look at the ALT and AST, which are your liver function tests. People do what's called an alkaline phosphatase along with that. I think that oftentimes with liver disease, you'll see an elevated ferritin, which is storage of iron, which you'll sometimes see. But the primary ones are the, at least for what we're going to talk about today, is the ALT and AST. Now, normally, the values are somewhere from 15 to probably low 30s, maybe up to the higher 30s. When I start seeing people with these liver function tests getting into the 30s, even if they're in the normal range, it implies that there's some form of inflammation going on in the liver. So you can do hepatitis B and C screening, and you can do certainly by history and intuition know about alcohol. I think the rule of thumb for most people that have alcohol problems is whatever amount they tell you they're drinking, if you double it, you'll have a much better idea. People are just embarrassed. But knowing how much, and it's not about confrontation, it's about, letting them know, and most of them do know the danger. It's an addiction. And we know now that, people that have alcohol addiction need therapy, need help, not just rehab and stopping them from drinking. It's an addictive personality that does this. So what we're going to talk about today is fatty liver disease. This is the epidemic that we're going to see in this country. It is fatty infiltration of the liver. It is called non-alcoholic steatohepatitis, which means fatty inflammation of the liver unrelated to alcohol. And again, we talked about how it moves in that spectrum all the way to cirrhosis and cancer. And having fatty liver like this off the top increases your risk of liver cancer by 20%. So what we find is that most of fatty liver is due to insulin resistance. What we find, I'm going to give a little background on this that it's important to understand is, you're basically storing fat in the liver. So it's one of those areas that just like storing excess fat in adipose tissue. This is kind of the liver fat storage that we get from insulin resistant. And a lot of people in this country have insulin resistance, and it's important to understand that insulin resistance is just not diet. We're going to talk some about diet, which is a very important part of this. But what you find is that even more people have mitochondrial disease causing insulin resistance. And what you find is we have our mitochondria, our furnaces making all this energy for us, all this ATP. So as a result of the biochemical processes, we end up having these toxicants, these byproducts of combustion.
We hope you found this training helpful. To continue watching this training and others, please visit eastwestmedicaleducation.com and click on the tab in the clinic to subscribe.